every diagnosis that you know of, they can create a question from it. And then you have to read through the story. It just is a narrative. But there is a diagnosis for this problem, and this is how they will present it. If you know about appendicitis, there's the way they can present it to know what appendicitis will present about. And that is what the next generation NCLEX is all about. So how do you tackle these kind of cases? Like I said, try to figure out by the third line. If you can't, try your best to go to the fourth line and trying to reinforce the information. And that's all. And don't make it so complicated and then thinking about so many diagnoses. That's where you go with the buzzword, right? 32-year-old female. She's G3P1. I'm underlying the keyword. She's had 3 babies, right? 3 pregnancy. This is a chief complaint. Painless vaginal bleeding. That's a buzzword right there. Painless vaginal bleeding. This is why she came in with. So you have to focus on it. Every time they said, came in with the complaint, this is your boy. This is the one you're going to focus on. It tell you why the patient is in the hospital. And so you can make a diagnosis without addressing that. That started but an hour ago. It's an acute problem. She described the bleeding as what? Bright red, and states it soaked through the sanitary pad. Bright red, painless vaginal bleeding in a 28 weeks pregnant lady. I don't even have to give you any more information for you to be able to make a diagnosis. She denied, this is very important. There's no cramping, so there's no pain, right? There's no contraction, and there's no abdominal pain. This is also a buzzword. Just like that, you should be able to figure out what this patient is suffering from. The patient pregnancy has been complicated by what? Gestational diabetes. She has gestational diabetes. This is what the NCLEX would do. You always want to focus on the chief complaint. Why would I spend 5 lines or 6 lines talking about why the patient came in? All of a sudden, I'm telling you something else what the pregnancy was done with. This is just telling you it's not gestational diabetes. I'm just trying to distract you from the main thing. That's what, so when you see a case study and all of a sudden they're talking about something else, ignore it. The pregnancy complicated by gestational diabetes. Okay, manage with diet. Who cares? She reported good fetal movement and no prior episode of bleeding. Yeah, she's never had any more bleeding before, but this is the first time all of a sudden she has painless vaginal bleeding that is soaking through a sanitary pad, and there's no abdominal pain, no cramping, and the bleeding is bright red in nature. She's slightly, heart rate is a little bit of blood pressure, but otherwise her vitals is normal. She's stable. The uterus is gravid. That means she has a baby there. She has no abdominal pain. The fetal heart tone is what? Heart rate is 145. That's normal, right? And it's moderate variability. Good sign. Baby is doing fine. There's no deceleration. And there's no contraction. Telling you everything is doing fine. Everything is normal. You do the ultrasound, and there's intrauterine pregnancy. There's a baby there with low-laying placenta at the cervical os. Can you figure out what is going on? This is your case. What is wrong with this patient? What do you think? Female, pregnant, painless vaginal bleeding, that is bright red. She has no abdominal pain. The vitals is normal. There's no contraction. And you find low-laying placenta at the cervical os. This is the way they were presenting. They have no other way. This is the normal way they come into the hospital. They may change the age. They may change the the weeks of pregnancy, but this is the way. They have to give you the buzzword. So, which of the following intervention the nurse should anticipate? So, what do you think the doctor is going to do for this patient? Which of this? The nurse should anticipate what? A vaginal examination to determine the source of bleeding, perform serial abdominal hemoglobin and hematocrit test, monitor for what? Contraction, pelvic rest, betamethasone, and two 18-gauge peripheral IV. Which of these do you expect in the nurse should expect? Based on the case I've given you, what do you think she should expect? I can tell you, she needs two large bowl IV, right? We got to resuscitate the patient. The baby is what? 28 weeks. Well, if we have to deliver, it's like we have to prepare the lung, mature the lung. So the steroid will be necessary for the fetal lung maturity. What else do you think about pelvic rest? Monitor for contraction, perform serial hemoglobin hematocrit, or perform vaginal exams. Patient has vaginal bleeding. You know what the diagnosis is. What do you anticipate in the plan of care? So what do you think? What do you think the nurse should do? Or should anticipate? I've given you two of them. The kid may need some steroid but not right away, unless they have to take the patient to surgery. And they may need to give the patient IV. Anybody who's bleeding needs some IV, right? We have to monitor for contraction. We have to check H&H, and we have to do vaginal exams. So I can tell you, you should monitor for contraction and make sure mommy is not going to preterm labor. Secondly, you need to check their blood, right? Because of bleeding, H&H, you got to check for that. And then there should be pelvic rest, nothing go into the vagina. And you should not do a vaginal exams. We already know what is going on. There's no need to put your finger there. The placenta is at the cervical arch. You should not put your finger there anymore. So A is not indicated. So that is the key. Always watch for this vaginal examination for this patient. We should not do that. So therefore, what condition is the client most likely experiencing? I know I saw a bunch of people get the answer. So this was a placenta previa. Why? Is painless vaginal bleeding. Is after 20 weeks. There's no cramping. It's bright red blood. Baby is doing fine. Mommy look fine. The blood is not dark in color. There's no stop of uterine contraction. Therefore, your differential will be placenta abruption, uterine rupture, right? But these are not the same, or blood show, but these all shows signs and symptoms of placenta previa. So I did not give you options. I want you to type it. So you can type it and you can get an answer. Now, the client experienced a sudden massive bleeding and a drop in the hemoglobin level. You see, now she's bleeding and the hemoglobin level drop. She has placenta previa. What do you think you should do? What is your priority action? If you watch my prioritization video, I always say, do something to save the patient. You have to be sharp. There's no ABC here. Okay, do something. Which of these options, when you do, is going to save the patient? Prepare the patient for emergency C-section. Administer additional betamethasone to accelerate fetal lung maturity. Increase the IV fluid to compensate for blood loss, and place the client in the lateral position and continue monitoring. Always read the full answer choice. Think about the implication of the answer choice. This is a test-taking strategy. Like, look at the question. There's nothing they can ask you in the NCLEX that never been asked before. There's nothing they may ask you that is not clinical. So when you're choosing an answer, you're choosing a clinical scenario. If you're choosing a clinical scenario, you're telling yourself, if you're taking care of this patient, this is what you would do. So think about the answer choice you pick. Don't pick it just like that. Whatever you pick, you say, why am I picking it? What is the implication? If you're going to give the patient fluid, look at the scenario. What is happening to the patient? If you think you need to place them on the lateral position, look at the scenario. If you think you need to prepare for C-section, look at the scenario. What is going to achieve? And then you take ownership of your answer choice. You know, I'm picking this because of so and so. So whatever you pick, just think about it. As you can see, I said the client is experiencing what? Sudden, massive bleeding. That's your buzzword. This lady is bleeding and she has what? Placenta previa. Placenta previa. This is the uterus. And the placenta is sitting here like that. And we have massive bleeding. Okay. And the hemoglobin is dropping. Shortly, mommy is going to be in shock, right? If you decide to give them fluid, well, it's not going to prevent the ongoing bleeding. We got to save the mommy and we got to save the baby. Increasing fluid rate to compensate for the blood loss. Fluid cannot compensate for the blood loss, no matter what. You will need fluid and blood and everything. The answer choice is not complete. It does not make sense. Giving just fluid will not help with this situation. So we have to do something better. Okay, you have to do something better. Administer additional steroid to accelerate the fetal lung. We got to save the mommy, otherwise the baby is dead. So this is wrong. Okay, placing the mommy on the lateral position, sure, it will help with the hypotension. It doesn't stop the bleeding. Only thing that is going to stop the bleeding is we go and do C-section, and that will help with the prevent the bleeding, and we save the baby and we save the mommy. So that's how you approach this kind of question. It's a prioritization. This is what is going to stop everything. So that's the most likely right answer. Okay, so that's the case. It's placenta previa and then everything that you need to know about. This is the explanation. Like in case of placenta previa with severe bleeding, the source of the hemorrhage is from the mother, right? The only way you can stop the bleeding is delivery of the baby, not giving them blood. You can transfuse them, you can give them fluid. It's not going to work. Of course, the mommy, they're not going to push the mommy to surgery right away. They will need blood as they go in there. But prepare for in this situation. This is the likely position. And this is the second question. You may know case. You may know I've seen it before. This is not everybody know about this, but I give you I present it in such a way to understand it. So you have a 32-year-old female. Okay, this is a good OB questions you can ask you. You have to know a little bit about it. 32-year-old woman present to the clinic. She's 6 months postpartum. She already delivered a baby. With what? Complain of what? This is the chief complaint I told you. You have to focus on always the first two lines. Persistent fatigue. We have fatigue. One, difficulty breastfeeding. She can't breastfeed and menses are irregular, right? She described feeling increasingly she's weak, right? I'm underlying the keyword. She cannot tolerate stress or engage in activity. What is telling you this? She reports sweating and lightheadedness and weakness. Okay. She reports what? Previously, she has complicated delivery that during the delivery, she had severe hemorrhage. This is another buzzword. While she was delivering a previous baby, she had severe hemorrhage that required transfusion. So she had hypotension. She stated that her breast milk production was minimum. She never had breastfeeding. She couldn't breastfeed, right? Which led to she fed the baby using formula. Now she report of what? Cold intolerance. Does it give you a clue? She has what? Weight gain. And she has thinning of the hair. She denied any headaches or visual changes by mentioning a lack of what? Libido and no return of a menstrual cycle. This has a lot of information because there's a bunch of conditions that is involved. So let's get it clear. Keywords I underline. If you don't know, you can write them down. These are the keywords. 6 months postpartum. That means she already delivered a baby before. After the baby, now she's fatigued. She never breastfeed because she can't breastfeed. And menses are irregular after she had a baby. She cannot tolerate stress. She's weak all the time and dizzy and sweaty. She had a postpartum hemorrhage, really bad one, when she delivered a baby. The breastfeeding never occurred, like I told you. She's reporting of cold intolerance, weight gain, and thinning of the hair, and also decreased libido and menstrual cycle. When you examine her, she's alert oriented, her skin is dry, she has coarse hair, she has thinning of her eyebrow, a deep tender reflex is decreased, pubic hair is not there, and her vagina is atrophic. It cannot be hyperthyroidism because most of her symptoms are not uppergoing. There's no hyperthyroidism will show reflex is going up. Her skin is not going to be, she won't gain weight, she will lose weight, she'll be tachycardic and all the symptoms will be really, really hard. So these cannot be. But this is all consistent with this. The key word is postpartum hemorrhage. That is your buzzword. Postpartum hemorrhage led to all this problem. Once again, postpartum hemorrhage led to all this problem. If you never heard it before, that's the problem. And then we get some labs. I will show you what happened to the labs. This is the labs. Everything is down. TSH is down. Prolactin is down. ACTH is down. Cortisol is down. Everything is down. I see Addison disease. I see hypothyroidism. So all this is down. Anybody know what is wrong with this patient? What is wrong with this patient? If you never heard it before, look at the problem. She has symptoms of thyroid. That is a dry skin, coarse hair, thinning, decreased reflex. So this she has hypothyroidism. That is the cold intolerance, right? And weight gain and thinning of the hair. So she has hypothyroid. Then she cannot tolerate stress because of hypoglycemia, right? She's sweaty all the time when she's exercising, right? Her cortisol level is low. She has adrenal insufficiency. So how can you have adrenal insufficiency? You have hypothyroid. She couldn't breastfeed because she has no prolactin, so prolactinoma. So she has hypothyroid, she has a prolactin deficiency, she has adrenal insufficiency, vaginal mucosa is dry, and then she has decreased libido. So if FSH, a gonadal level is down. So she has no gonadal, do hormone, sex hormone. There's no sex hormones, there's no thyroid hormone, there's no cortisol. She has adrenal insufficiency, she atrophic mucosa. What do you think is going on? I can tell you it's not hypothyroidism because you can't have hypothyroid and have adrenal insufficiency at the same time, and you have low prolactin. This is a condition called Sheehan Syndrome. This is something you should, if you've never heard it before, it happens all the time. And that's this one. And the key word is postpartum hemorrhage. And that causes hypotension. And what does that happen? You go to your pituitary gland in your brain. The pituitary is divided into posterior pituitary and anterior pituitary. It affects the anterior pituitary, which is responsible for TSH, is responsible for FSH, is responsible for LH, is responsible for ACTH, is responsible for prolactin. The pituitary is where you have the posterior is we have pitocin and ADH. It affects this side, just the anterior. So there's no TSH. That's why she has hypothyroid symptoms. There's no FSH LH. That's why she has gonadal problem. She has never had any menses. A prolactin is very, very low, so she cannot breastfeed. ACTH is also very, very low. She has adrenal insufficiency. This is common in pregnancy. That's why postpartum hemorrhage and when you have hemorrhage during delivery is a big problem. You have severe, the most common is placenta abruption. When you have placenta abruption, this can happen. You have severe hemorrhage and you have infarct of the pituitary, posterior pituitary, and you develop Sheehan syndrome. So it look like she has gonadal problem. She look like she has adrenal insufficiency. When she's sweaty and lightheaded, when she exercises, because she's hypoglycemia. Her cortisol is very low. She has signs and symptoms of hypothyroidism, signs and symptoms of prolactin deficiency. We call it Sheehan syndrome. So if you've never heard it before, you should Google it and you can read about it. It's a good OB case they can give you. So I already told you what is the underlying pathophysiology for this. It's not the destruction of the thyroid gland, right? It's the pituitary gland getting infected. So it get infected and then it get destroyed, right? It's not due to increased prolactin because there's no more prolactin. It has nothing to do with adrenal atrophy. The main idea is the pituitary gland shut off, and adrenal gland cannot work, the thyroid hormone cannot work, your gonadal, you can't produce sex hormones, you can't have all the hormones that you need as, and so your libido and everything go down. So that's Sheehan syndrome. So which of the following the next you educating the client? The need for lifelong hormone replacement, likelihood of spontaneous recovery from the pituitary, or importance of increasing dietary protein for recovery, or the risk of diabetes insipidus. This is a content. I explained to you what is the main problem. You know the patient is lacking all hormones. So the most important is to replace the hormones. She's not going to do anything without the hormones. So replace it. This is also a content. I explaining to you the pituitary gland, the posterior pituitary is not affected. And therefore, you're not going to have diabetes insipidus because diabetes insipidus, you're going to have ADH problem, but it does not affect the posterior pituitary, right? Importance of increasing diet. Diet was not their problem, so you should not pick it. There's not going to be spontaneous recovery because the pituitary gland is dead. So the best thing is to give the hormone replacement. So you need a bunch of hormones to be able to function. Which of these hormones do you give the patient? Now, you know, which of this do you give it to them? I already give you the answer. Which of the following hormones this nurse should expect in the plan of care? Right? Steroid, levothyroxine, estrogen, progesterone, growth hormone, and prolactin. I can tell you they need steroid. It's a selected apply. They need thyroid hormone. They need estrogen and progesterone. That's for sex hormones. Growth hormone is usually you don't need it, but if the person is not growing, you can give it to them. But there's no prolactin. There's no replacement of prolactin. So if you don't know, that's the content. We cannot make prolactin. It's a natural production in breast milk, production of milk. There is no prolactin. So it's not all of them. We have not been able to reproduce prolactin. So nobody can reproduce prolactin. So it's A, B, C, and D is your right answer. So there's no prolactin. So E is not included. And this is also, I need to show you, this is the content. Which of the following orders the nurse should question? Levothyroxine must be started before prednisone. Estrogen and progesterone may be started together. Steroid must be started with levothyroxine. Prednisone may be started together with estrogen or progesterone. Which of those should you question? But the way to answer this question is to understand the situation. The patient is adrenal insufficiency, right? He has adrenal insufficiency. And then they have hypothyroid symptoms too. And they have gonadal problem, gonads. So which of these orders should you question? Look at the combination and see which one is bad. You can give steroid together with the progesterone. It's not a problem. This is sex hormone. It's not going to affect it. So that's fine. The answer choice is between A and B. C, I'm trying to guide you. So this can be eliminated. There's something you should know between steroid and levothyroxine. And who knows the reason why? If you know, you can type it. It's between thyroid hormone and the steroid hormone. There's a content there. So which one should the next question? Is it A or C? And if you think it's A, you got to explain it why you think it's A. There's a content here, thyroid hormone and a steroid, corticosteroid or prednisone. Why you got to start one before the other? Which of those you should question? And let me give you the content. What the key thing is, what is the thyroid hormone going to do? What is the function of the thyroid hormone? What is the function? What is the function of the thyroid hormone? It's for metabolism. So if I give you thyroid hormone, your metabolic rate is going to go up. Remember, it's going to stress you. You're going to be in stress. That's what it does. That's why your heart rate goes up. Everything goes up. If I give you thyroid hormone, you become stressed. Everything goes up. But what is the problem? This patient, they have adrenal insufficiency. They cannot tolerate stress. So if you give them thyroid hormone and they cannot tolerate stress, you put them in adrenal insufficiency, they go into crisis. And therefore, you should give them steroid first. Give them steroid first. And after a couple of weeks, then you give them levothyroxine. So if you have a patient who has adrenal insufficiency and hypothyroid, you want to give them steroid first because thyroid medication will always stress you. If you can't tolerate stress, you go into adrenal crisis. So they should take the steroid for a couple of weeks before you start the levothyroxine. So that's the key aspect of that. So this is the question the nurse And you should not start levothyroxine before prednisone. You should start prednisone before levothyroxine. And this is the end of the class. This is Sheehan Syndrome. If you never heard about it before, you should read about it. But that's a good NCLEX question case study you may find, especially in the OB. And thank you for watching. Before I go, if you want to join our class, this is coming on the 1st of the year, 2nd to the 12th. We'll work on a bunch of case study, how to answer questions. These are the content, this is where to register, this is the deadline. And then I hope you learned something today. Take care of yourself, and then good luck in your exams. Bye-bye.